Good morning, everybody. The special session of Sposi, Strabismology and Pediatric Ophthalmology Society of India. First speaker will be Dr. Santhan Gopal. He doesn't need any introduction. He is a past president of All India AIOS, and he is a very good. He is an authority on amblyopia as well as strabismology and pediatric ophthalmology. Dr. Santhan Gopal is going to start his first lecture on orthoptech.
Good afternoon. My first talk is on orthoptech. After that, I have to take leave with the permission of the chair, since I have a talk somewhere else. Now, the machine orthoptech is used for treatment of a number of conditions like amblyopia and related conditions, fourth nerve palsy, sixth nerve palsy, and in treatment of nystagmus, and improving in hand-eye coordination, also improvement in stereopsis, particularly in for reasons we do not know why the stereopsis is reduced. You can use this, and it's used in treatment of problems, ocular problems in cerebral palsy, and also to an extent in optic nerve problems. Now, how do I know that it's all used in these? More than 85 people all over India are using this with perfectly happy results, including the current president, Center for Sight, and Arvind Eye Hospital, and a few other important places. All over India, from north to south, they are quite happy using that. These are the references given by them. Now, if you understand this, you understand orthoptic, why it works. Basically, it depends on the principle that there are impulses within the brain which come from centers like frontal eye field area and parietal area back to the occipital cortex. And when they come back to the occipital cortex, they fast forward the impulses coming from the retina to the occipital cortex. This is where the crux of the problem is in amblyopia, that there is a blockage at the level of level 4C beta in occipital cortex, and therefore there is no further transmission of impulse from occipital cortex to the temporal cortex, which is exactly the place where the vision is analyzed. The occipital cortex works only as an image transmission center. It does not have its own brain to understand the quality of these images. It passes it on to the temporal cortex, which analyzes and sends it back to the occipital cortex via the cognition center. See, it's a very complicated process, the whole vision. What you see, the brain has already knows. If the brain knows what you see much faster. If the brain doesn't know what you are seeing, it takes longer time. And if the brain never knew what you are seeing, you will never see. So it's actually you see with the brain, not with the eyes, but you see with the brain with the help of the eyes. That's the one you need to understand. Now, many people, this, as I told you, this is the place where in occipital cortex the problem is due to glutamate release, vision happens at level 4C beta. This glutamate goes to the postsynaptic membrane where it releases nitric oxide. The nitric oxide travels back and further transmits the impulses forwards. In amblyopia, there could be any number of reasons why there is a problem. There could be reduced glutamate reduction, there could be absent glutamate reduction, or there could be absent nitric oxide production. All these things lead to, we don't know, because at the micro level, we do not know exactly, but all we know is the problem is at the level 4C beta level in the occipital cortex. That's why there is visual problem in amblyopia. So the orthoptech tries to utilize the impulses present within the brain. They are already existing. We are not creating any new connections. They are already existing. So when peripheral retinal, I'll show you that in a few seconds. If you understand, this is the most complex picture you need to understand. Whenever you stimulate the peripheral retinal cells, M cells, otherwise called as magnocellular cells, the magnocellular cell stimulus, when it is stimulated, the impulses reach the parietal lobe much before the occipital cortex is stimulated by the P cells. The P cells are in the center, whereas M cells are in the periphery. The rate of transmission of impulses along the M cells is much faster than it is with the P cells. And secondly, the attention center is within the parietal area, and therefore the parietal area has an access to the M cells much faster than the P cells. So the brain already knows what it is seeing because of the faster transmission along the P cells. Now all these things may sound Greek and Latin, but the orthoptech works because of this small principle that the M cell stimulation leads to repeated P cell stimulation, which is the central area which has problem in amblyopia. That is why our ancestors said Sarvendriyanam Nayanam Prathanam, because this is the connection, how the eye is connected to with the brain and how the vision is processed in the brain. The most complex. Now, although the instrument is instrument looks like this, instrument is very simple to use. Even children can set it up. It is even easier. You can see here how it is set up. It is set up like a TV, not very difficult, but at a particular height and a distance from the this thing. I can see the children as young as 3 years and 5 years and adults using this instrument. Can reduce the volume on that. This is a 5-year-old child doing that and pointing out the light with the laser pointer, and this is a 3-year the second one. Start this child. Okay, this is a second year. Reduce the volume of the video, and you can see this 3-year-old child with intermittent avison squint pointing out the light with the fingers. And what is the connection between the fingers and the eye? The simple connection is in the frontal eye cortex. In the frontal eye field area in the cortex is closely connected to the hand area in the cortex. Whenever the hand moves in the direction in which the eye moves, the two are stimulated simultaneously. The stimulation of frontal eye field area in turn stimulates the occipital cortex, and stimulation of the occipital cortex obviously the hand-eye program one and also the she is pointing out of the child. The lights you can see that she is pointing out with all the lights which come on. So this is the simple principle on which the orthoptech works. Not simple but complicated principle, but simple to set up, and even you can see how she is pointing out the lights which come on. Whenever the hand moves and the eye moves in that direction, the frontal eye field area is stimulated. The hand movement and the frontal eye field area of stimulation are closely interlinked, and therefore every time the hand moves, the frontal eye field area is stimulated. Stimulation of the frontal eye field area in turn stimulates the occipital cortex, and stimulation of the occipital cortex in turn leads to excessive glutamate release, which stimulates the vision. This is the principle on which orthoptech works. If you have any doubts or questions, you can just copy this, take a photograph of this QR code. All the details are given in that. You can read through that. There is a DSTC course now which I have to go. If anyone is interested, you can come and take a picture and discuss it with me, any amount you want. Because 6 minutes is not enough to tell you about my 2 years of experience with this equipment. Dr. Shreya is another person who is using it. She will tell you more. Thank you very much.
I have used and I have seen the results, wonderful results, especially for amblyopia, stereopsis and contrast sensitivity. Still we are studying for strabismus, so I will guide because we have not seen that result. Thank you.
Hello. Good morning, everybody. Dr. Santhan Gopal has demonstrated his most modern equipment, especially for amblyopia. But as far as India and all developing countries are concerned, is it possible to use such a costly equipment for all the patients? Because the prevalence is very high, more than 8% in underprivileged populations of India and developing countries. So I'm here to tell you something easy solutions for developing the treatment of amblyopia. Well, for amblyopia management, we have to think and rethink beyond visual acuity 20/20 or 6/6 vision. Everybody is trying to improve the vision up to 6/6, and after 1 month, 2 months, 3 months, or 6 months, the vision goes back again and again. The regression of visual acuity is also very high even after treating the patient for so many months. So what is the reason? For that, there are certain things that I am going to tell you now. Another thing is that the vision which we improve, the visual acuity, even if it is 6/6, it is a low level vision because it has no proper contrast sensitivity, discrimination and depth perception also. So a strategy to achieve high level and stable vision in a user friendly way with good compliance, that too at home. Let us see. It is my experience of only 50 years in this particular branch, and I am working on this amblyopia and all these things for the last 15 years almost. Well, over 100 years, in spite of trying different regimes, amblyopia management remains confused and unsolved. The prevalence is over 2 to 4% in worldwide population. Over 1.2% persons live with compromised visual related quality of life and being labeled as visually unfit when they go for different jobs, specific jobs. Let us come back to the definitions of amblyopia. They are continuously changing. There is changing concepts for amblyopia. We were taught, or it is also given in the textbook, that amblyopia is a unilateral or bilateral disorder. But as per the recent advances, it is a binocular dysfunction that both eyes have multiple visual function deficits like inability to discriminate crowded objects, color contrast, stereo acuity and so many things. Even if the better eye has almost vision 20/20, means vision is not of high quality. And the regression problem I told you is more than 25 to 50% cases they show regression. So again coming back, that amblyopia is a binocular dysfunction. In fact, the major mechanism is not the lazy state of the one eye, but the active inhibition of the amblyopic eye by the dominant eye, which disrupts the equilibrium between the excitatory and inhibitory signals. It needs to be tackled binocularly. There are more than 100 references for that. The people are using iPad, that to the binocular iPad treatment by binocular treatment. It has been observed by many researchers that unless the contrast sensitivity and the stereo vision, they are not developed properly, the visual acuity will regress again and again. So our aim is to target towards high level and stable vision by correcting the plethora of other visual functions apart from visual acuity, that too binocularly, as it is a binocular dysfunction. There is a complementary faster route to achieve high level and stable vision without any instrument or equipment. It's a very simple thing. Enhancing the contrast, there are so many references. During 2009 also they have started enhancing enhancing the contrast sensitivity function through action video games. When playing video games are beneficial, the specific video games that is the latest one is in 2022. But when in 2014, Hussain and et al., there was a paper that the challenge of developing video games for improving contrast sensitivity. There are challenges. And we have accepted that challenge and we have developed certain games for improving the contrast sensitivity. And we have uploaded it on Lazy Eye Master Games on Android Play Store. The basic of this game is that we have to treat the other multiple visual functions deficits also, and especially the contrast sensitivity game is like this. There are different colors of the percentage of the same color. You have to tap that particular color and score the marks. Then one more axis game that is for specially for meridional amblyopia, and children can easily play. You can give tab to the children beyond after 2 years only. Screen time should be given to the babies after 2 years, that too only for 30 minutes with a 60% illumination. Thank you very much. You are most welcome for the next conference, Sposi conference in Rishikesh on 9th and 10th December, dedicated to control blindness. Thank you very much.
Thank you, sir. Thank you for a wonderful presentation on amblyopia. Sir has shared his 50 years experience in amblyopia management. Both Dr. Santhan Gopal and Dr. Pradeep Deshpande sir have dealt with an important topic on amblyopia. Hereby I request Dr. Shreya ma'am, Dr. Shreya Shah, for a presentation on paralytic strabismus. Dr. Shreya is the director of Drishti Eye Center, Drishti Eye Hospital in Dahod, and she is doing wonderful work in strabismology as well as oculoplasty and trauma. Over to her. I think our Prime Minister Shri Narendra Modi has visited her center in Dahod, so it's quite a well-known place in Gujarat.
Thank you so much.
And Drishti Eye Institute in Gujarat is one of the best institutes in India, where you can go there and stay with those people, with Dr. Shreya Shah, and she will teach you how to evaluate, how to assess everything, amblyopia, squint and pediatric ophthalmology. She is here, you are very lucky. Please listen her carefully. Thank you.
Thank you so much, Dr. Deshpande sir and Dr. Rishi, for a kind introduction. Hello. Hello. Thank you so much. Thank you. Thanks for inviting me. I especially thank Dr. P.K. Pandey sir, Dr. Deshpande sir and Dr. Rishi for inviting me here. I'm going to speak on paralytic strabismus, and if you look at the data at Drishti Netralaya, out of 3697 patients, we have almost 237 was having 50% sixth nerve, 78% third nerve, and 109 patients of fourth nerve. Along with that, Mobius syndrome, paralytic varieties of MDS, and traumatic paralytic stress. And these all data are already published in IJO, 13-year experience of paralytic strabismus. If we look into the paralytic strabismus, we have to know the where the cause lying. So there can be a neurological cause, there can be a myogenic cause, there can be a cause at neuromuscular junction, or certain syndromes like Millard-Goebel syndrome, Roman, Fowey syndrome, Mobius and Amadeus, and of course DRS. So diagnosing restriction versus paralysis, we have to know for cyclic velocity measurements, force duction test, force generation test, IOP, and lead pressure changes in the side gaze. And we all know about dog on leash phenomena. So history is at most important whenever you are looking for paralytic strabismus, because whenever there will be a long-term pulses, there will be a true tilt. So you have to compensatory head posture tilt, you have to differentiate between true tilt and ocular tilt, and can be amblyopia. But if it is recent origin, patient will pass point, and sudden onset of whenever is sudden onset of paralytic strabismus can be diplopia, confusion, and can lead to nausea, vomiting also. So this is very nice video showing the recent origin of palsy, where she is pointing there is a pass pointing, so that you can diagnose it is a paralytic strabismus which is of recent origin. Ocular motility test should be duction, version, primary deviation, secondary deviation, and look for inhibitory pulses and gaze specific IOP. So you have to see all the things, all the specific movements, including ductions and versions. So that will tell you everything about ductions and versions. Deviation, we have to measure. You can see that is left eye fix. This is almost not ortho, but it's almost ortho. But when right eye fixed, it's so you know secondary deviation is always more than primary deviation. Diplopia workup has to be done, crossed and uncrossed. Haze screening support should be taken. Diplopia free field should be checked, and we must know the principles between diplopia and haze charting. So and the most important part over here is FDT and FGT. So when you do force duction test, if it is positive, you must know that it is a restrictive varieties and not the paralytic varieties. Of course, there can be a paralysis, a secondary force duction positive test. So exaggerated FDT also to be done for superior oblique, and then force generation test. So when the patient looks towards the action of muscle, and you can feel the force in your hand when patient tries to move towards the paralytic side. So there is a, we can do in children with a Q-tip also, that is a force generation test. You have to document everything. We have our own software, so we document each and everything of strabismus. We have to take support of radiological investigation like CT scan, CT, angio, radiological investigations like MRI, and dynamic MRI is at most important whenever dealing with the paralytic strabismus. Sometimes electromyogram. How do we manage? Goals for management is restoring alignment, good vision, good stereopsis. So there are non-surgical management up to 6 months, can be prism in glass, Fresnel prism, occlusion of one eye, segmental occluding, or injection Botox. So prism in glasses is the important part we can do temporarily, or sometime we may have to give Fresnel prism, segmental Fresnel prism, or we can go for Botox or BP. We have to take support of EMG to do this. So dose and combination, it is a purely surgeon's choice. So when we talk about horizontal paralytic, this is first is a 6th nerve palsy, and this is the algorithm which I am showing for 6th nerve palsy, what to do when there is FGT positive. So I will not read everything, but it can tell you everything about this. So whenever there is a good movement, you can just simply do plication. So plication works very well when there is a at least crossing the midline movement. So that paralysis will be taken care by plication very well. I usually do double fixation, so you have surety of the surgery. If eye does not roll over after even 6 months, you have many procedures available like Hamilton, transposition of SR and IR, Jensen's procedure. So many procedures are available, even partial VRT and Scott Foster's procedure. So this is the patient post-operatively. In pre-operatively, we have seen this patient, and in this patient we have done modified Nishida's technique. So we just pass the suture 8 millimeter from the insertion, and then tie it with the non-absorbable suture 16 millimeter from the 20 millimeter between SR and IR. So this is a modified Nishida's technique, and this is post-operative movement of the same patient. So it works very well. Convergence fixes, you have to differentiate between saggy eye, heavy eye, and knobby eye. And then again the paralytic strabismus, this patient presented to us which was on mild exotropia, and she wanted only one eye to be operated, no non-committant strabismus. When we took the patient in and we did anterior segment OCT, we came to know that there was an insertion of malinsertion of medial rectus. So it was quite back. We put it back at the place, and then this is the post-operative of the same patient. So partial laceration of muscle, everybody knows how to search and fix it, so that can be a cause of this. Flap tear of the muscle also can cause for the paralysis later on. So you need to treat immediately. When there is traumatic third and sixth, both nerve palsy, usually eye is a primary gaze ortho, so don't do anything. Duan's retraction will not talk here. Mobius syndrome also, it's very difficult to take care. Cyclovertical, I'll not go too much into detail of it, but we can just discuss little bit algorithm, how we diagnose. Before that, we have to see traumatic IR palsy, which is very less, but less common, but still it works well with the steroid. Unilateral fourth nerve palsy, Parkes 3 steps test is a very good examination test. Double Maddox red road test also. So congenital palsy, acquired palsy, and bilateral palsy may be asymmetric. So this is the algorithm of whenever there is IO overaction, there will be V pattern, and more than 15 prism difference, you can do all the treatments available for this. Assessment of SO tendons laxity also has to be done. So when there is SO palsy, along with that, this is the algorithm shown here. I'll not read each and every one of this. Bilateral SO palsy, there may be a patient may just complain of tilting doors and everything, but sometimes that can be a ortho in primary gaze. So you need to check for the bilateral SO palsy, and then definitely there will be a V pattern. So you need to take care according to that. Fourth nerve palsy, that is a traumatic fourth nerve palsy, and trochlear disinsertion also can cause this. SO overaction will be in IO palsy, which is very, very rare, but still we got 1 or 2 patients. And this patient we had done silicone expander in SO with non-absorbable suture, and that worked very well. So this is post-operatively. MEDS, I'll not talk too much about that because it is a separate, and this is again an algorithm of MEDS, what techniques we are doing, including modified Nishida's technique, which works very well with MEDS specially. So you need to take care of everything when you do. And third nerve palsy, the time is over. Should I continue or not? It's too much. Third nerve palsy, it's okay? Should I continue or it's okay? Because you need to speak. It's okay? I can? Okay. So this is a partial third nerve palsy. Again, pupil sparing and pupil involving, you have to take care of that. MR fixation and periosteum to the LR is the one treatment for choice. So here we are showing the periosteal fixation of lateral rectus, and that works very well when it is long-standing third nerve palsy. In this patient, when there was a long-standing third nerve palsy, we did superior oblique transposition to the medial rectus along with R and R of horizontal muscle. So that is a post-operative treatment of this third nerve. Then later on, we operated for ptosis. Whenever there is a spread of committance, you have to take care of too much. This is myasthenia ocular, purely myasthenia gravis baby came to us, and when we did a tensilon test in presence of our anesthetists, and we can see now patient is after injection patient is able to move the eyes and in all moments regain back. So we have started this girl on pyridostigmine, and she's doing very well. DVD I'll not talk. DHD you need to identify very well. Thank you so much. I'll not go into too much detail. Thanks a lot.
Thank you, Dr. Shriya, for actually it's a composite presentation of all different kind of paralytic squint which you can encounter, and definitely will encounter sometime in your clinical practice. Just a word about vision. Remember that the eye which is fixing, it's not a rule that the eye which is squinting will always be paralytic. if there is a difference in the vision, and if the eye with normal vision is paralyzed, then the patient tends to take a fixation with that eye, and in that case the presenting squint which you, especially in cases of fourth nerve palsy, it can be confusing to actually diagnose them as fourth nerve palsy, because the normal eye will take a fixation.
Yeah, Dr. Shreya has shown her beautiful videos on different surgeries. Performing surgery on 6 nerve palsy cases, it's very difficult, very difficult. And she has shown it very nicely with all different new techniques and old techniques also. Thank you very much.
Thank you, sir.
Yeah.
Yeah, Dr. Rishikesh Mai, he is a renowned pediatric ophthalmologist from Nagpur. He is a very good strabismologist and amblyopia consultant also in Nagpur, means in center of the India place. He is a wonderful. He is going to present on limber approach of lensectomy for congenital cataracts.
Thank you, sir. At the outset, I would like to thank Sposi for this wonderful opportunity. I'll be presenting a limbal-based approach for lensectomy for congenital cataract. Actually, pars plana lensectomy is quite well known, and as everybody is aware that pars plana lensectomy becomes easier, especially for retinal surgeon, and with the risk that the uveal tissue, especially the iris, will not be damaged. However, it needs lot of expertise and also instrumentation. So Kansky et al. They came out with a technique for limbal approach for removing the lens. Everybody is aware that if the corneal diameter is less than 10 millimeters, you cannot put a lens. However, for congenital cataract, the best time to operate is unilateral cataract is less than 4 weeks, and for bilateral it is around less than 6 weeks, not only for giving vision but also binocular vision. But we cannot put lens in all these cases, so we simply need to remove the lens by using a vitrectomy. I'll just show the video, but before that, counsel the patient very well, counsel the parents very well. Counseling is most important part actually, because we need to tell the parents that surgery is just the beginning of the treatment, not the end. Actually, it is a long path of visual rehabilitation, which includes glasses, contact lenses, and a secondary IOL later on. Also, the frequent follow-up, frequent application of drops is very important. And in spite of everything, in spite of your best effort, the visual outcome may not be as desired. So preoperative preparation includes various investigations, especially rubella. Try to rule out rubella in these cases, because it might have cardiac side effects as well. So get a fitness from pediatrician and pediatric cardiologist. I usually send all my cases to the anesthetist beforehand, before the surgery, not on the day of surgery. And bilateral surgery, it's still a debatable topic, but if there is a risk of anesthesia, a bilateral lensectomy can be done. The video which I am showing, actually I did a bilateral lensectomy in this case. This was for the right eye. You go with the side port entry the way you go for adult cataract, and don't use viscoelastic agent. Just put a irrigation cannula. This is an unedited video actually. So irrigation cannula, and then with a 23 gauge vitrectomy. This was from Intuitive machine by Johnson & Johnson, no financial interest. In this machine there are two settings. One is irrigation cut aspiration, and the other one is irrigation aspiration cut. So initially you go with irrigation cut aspiration. Use minimal aspiration and minimal cut, right? Because we are going to create an opening in the anterior lens capsule. The calcified portion might be a bit hard, so in that case you can increase the cut rate to around 200 to 300 per minute. But initially don't try to remove the lens matter unless you are through with the anterior lens capsule. So create a large opening, because if you have to put a secondary IOL, we will be putting using the the capsular rim only. So also if the anterior lens anterior capsular opening is small, you might have a capsular fibrosis later on. So create a sufficiently large anterior capsular opening, and then we can go to irrigation, aspiration and cut, because now we are going to remove the lens cortex. or the lens matter. In pediatric cases, we don't leave behind the fibers. I mean, the lens fibers or cortical fibers are not seen the way we get in adults. So usually the lens matter, it comes out en bloc. So it's quite easier to remove this part, especially on the side opposite to the cutter. Uh, Ensure that you have removed all the cortical matter. No, don't leave behind any cortex at all. This is an important step because you are likely to touch the iris here and you are likely to leave behind the cortical matter, but both of these situations will increase a lot, will cause a lot of inflammation. Anyway, pediatric eyes are more prone for inflammation, so don't touch the iris and also remove the cortex in totality. The problem comes with the subincisional cortex here. We might be have a tendency of switching the ports. I mean, go with the vitrectomy on the other side, but don't do that, because the moment you come out with the instrument, the globe is likely to collapse, because the pediatric sclera is thin and the globe is collapsible. So basic part about this surgery, once you enter with your instruments, complete the surgery and then only you come out, so that there won't be any collapsing of the globe, no prolapse of the vitreous into the anterior chamber. Uh, I mean, once you have got rid of the cortex, then you create an opening in the posterior capsule. Again, you go with irrigation, cut, aspiration, minimal cut and minimal aspiration. But remove the, do the posterior capsulotomy only and only once you have removed the cortex. Otherwise, the cortex might, fall into the vitreous cavity. Once the posterior capsulotomy should not be more than around 5 millimeters. It may not be as large as the anterior capsulotomy. Once you have done the posterior capsulotomy, you can increase the cut rate to around 800 to 1000 per minute when we do the anterior vitrectomy. Do a thorough anterior vitrectomy. Remove the anterior vitreous phase, because even that can act as a scaffold for posterior capsular opacification, which might cause a media opacity, and ensure that there is no vitreous prolapse into the anterior chamber. And at the end of surgery, when you remove the cutter, you keep the irrigation cannula on, and then you do the hydrate, then you hydrate the side port so that the globe doesn't collapse and the vitreous doesn't come into the anterior chamber. Also, we inject dexamethasone in the conjunctivally. If you feel there is any, if you have any doubt about the wound integrity, you can apply suture here, because the globe is collapsible. So applying 10-0 Vicryl suture may be a good idea. On table itself, you do a refraction and check for the fundus and prescribe the glasses accordingly. Early post-operative treatment includes steroids, which are given regularly, in 1 hourly, and antibiotics. You might have to give oral steroids also. Syrup Predone, again, no financial interest, is available. You can give it 1 milligram per kg. Follow up the patient on the first day, third day, and look for AC integrity and AC reaction. At 3 months, you measure the intraocular pressure and measure the corneal diameter under anesthesia. And if it is more than 10 millimeters, you can apply a secondary IOL, usually around 1.5 to 2 years of age. Remember that when you are prescribing the glasses, you overcorrect, because we want the child to see for near clearly. So 2.5 to 3 diopters more than what you have got the reading on your retinoscopy has to be given. So the important point from literature search is that there is no significant difference between the visual outcome and complication rate with limbal lensectomy versus pars plana lensectomy. The basic thing is that earlier surgery is more important for better visual outcome and lesser chances of post-operative complication. When I was doing my fellowship in Shankar Nethralaya, we conducted a study to find out what are the predictors of glaucoma following surgery for a congenital cataract. It was published in Eye, and we found that the younger the age of surgery is the most identifiable risk factor. So the earlier the child gets operated for congenital cataract, more is the risk that he might develop glaucoma. Thank you. Thanks.
Thank you, Dr. Rishi, for wonderful presentation. I just want to what you said, when you are taking out the instruments back, there will be eye collapse. So in our institute, we have developed a wonderful technique which we keep it as a AC maintainer. So if you put AC maintainer, you don't have to worry about that, if any case you have to do. And all of them may not have retractors with them, so they can definitely go for rhexis, but the only point you need to take care, it's not an adult rhexis. It's not an adult capsule. It will not behave as an adult. It may go off anytime, so your good hand control is must. Thank you so much.
Dr. Mahi, your video was excellent. The surgery and surgical skills are really excellent.
Excellent.
I would like to ask you one or two questions. One question is it necessary to perform posterior vitrectomy all the time?
Yes, sir.
Sorry, anterior vitrectomy.
Antivitrectomy, yes, sir. Not only that, the posterior lens
Because
capsule.
there are two schools of thought. Some
Yes,
people
yes.
are doing it or some people are not doing.
No, but I mean, I will always do an anterior vitrectomy because even the anterior vitreous face can also act as a scaffold for capsular opacification, which might obstruct the visual axis.
Good,
So
good
we
point.
have to do that.
But one more thing I have observed in your case, there were certain calcified spots over the anterior capsule.
Yes, sir. There were. In this case, it was there.
It is said, or this was the finding of Dr. Daljit Singh, and these are known as DS spots. If you find any calcified spots over the anterior capsule, that means the posterior capsule is already absorbed. Already there is a, and vitreous is already open. These spots, they indicate like that. These are known as DS spots. I don't know whether that is correct or not, but this has been, there was one paper in our IGO that you have to, in all such cases where you will find any calcified spots over the anterior capsule, you might be in trouble. Take care that you have to tackle the vitreous also, please. Okay? Where there are certain surgical emergencies to prevent amblyopia and to provide visually related quality of life. What are those? I have only 50 years experience in this particular branch, and now let me tell you about the stimulus deprivation amblyopia, especially in high risk babies. First and foremost is the crucial step in managing high risk infants is to address the lesions and that obstruct the visual pathway from birth or during the early childhood. And always remember that one-sided lesions are more amblyopigenic. It is just like one-sided, everything one-sided is very dangerous. Whether it is amblyopia, whether it is a amblyopia or low also. It is one-sided is very dangerous. So cataracts that are present in one or both the eyes at or after birth in infancy can obstruct the visual pathway and lead to severe type of amblyopia, especially cases of one-eyed cataracts. Then ptosis, drooping of eyelid, which is covering the pupillary area, is also that can cause a intractable amblyopia. Corneal opacities, even the smallest opacity in the center of the cornea, maybe just 2-3 millimeters also, this can result into a dense amblyopia. It needs surgical intervention as early as possible. It is a sort of emergency. Then most of the studies up till now have proved that in congenital cataract babies, if they are operated before 18 weeks of age, this is the age that they have described that you should perform the surgery. What is the age? Before 8 weeks of age. So early. It has better visual outcome. If you perform the surgery on later on, there are so many types. The amblyopia becomes very dense. There should not be, and one more important thing is that there should not be a difference of more than 1 week between two surgeries of both eyes. Again, there will be a chance of more dense amblyopia. So delay in second eye surgery for more than a week is likely to cause severe grade of amblyopia. Then as per recent advances again, primary intraocular lens implantation are generally advised after the age of 2 years. Nowadays people are going for IOL as early as possible to give him the child a better visually related quality of life as well as good vision also to prevent the amblyopia also. Secondary implantation, the recommended age is around 2 years, after 2 years. Then now the few surgeons, they are going for multifocal IOLs also. They are preferred to prevent the amblyopia and to provide an essential near vision to that child. This is for last so many years I am telling, but nowadays people, they have started using multifocals. They are the most useful for that child to provide a very good near and distant both the vision at a time. Then our aim is, why we are doing it so early? Our aim is to utilize the every day of critical period of visual development so that amblyopia should not settle down and in the form of a permanent visual disorder. Yes, somebody has said that the amblyopia should be treated when the head is born but the body is yet to be delivered. Yes, we can tackle that maybe from 12th day onward also. We can keep 2 flickering lights over the cradle of the child or 2 amber colored dolls over the child, cradle of the child, and this can stimulate the eyes. We can start treating amblyopia, to start preventing amblyopia. Then critical period, let me tell you about the critical period of visual development. The critical period of visual development is the period when the developing visual system is sensitive to abnormal insult due to stimulus deprivation lesions. The critical period begins just after birth and peaks at 2 to 3 years after birth. Then one more period is that the sensitive period to extend, that extends up to 7 to 12 years. It has also good chances of improvement of visual acuity if properly treated. Then one more, people nowadays, they say that there is a visual plasticity in adults also, in adolescents and adults also. But as per the anomalism, as per the so many things, it is very difficult, goes on become more difficult and difficult. There are certain practical things, the tips and tricks, simple preventive solutions to utilize the every day of critical period of visual development and to stimulate the retinal cells. If there is a surgical delay, that usually happens for any reason of a few days or few months in high risk babies, the first step is to keep the pupil dilated every alternate day in cases of central, anterior polar and congenital nuclear cataracts. Keep small flickering LED lights over the cradle of the child during the awaking hours and do not forget to keep the cornea moist. This simple thing can prevent amblyopia, settling down the amblyopia. And in ptosis also you can put a small Tixo tape during the waking hours, put a flickering light and but take care of the cornea should not be dry. Then as per American Academy of Pediatric Ophthalmology and Canadian Academy, no screen time for any kind before the age of 2 years. Use of 10 inches spherical glass, you can provide if you are not, you perform intraocular lens implantation, you can provide them 10 spherical glasses, bifocal glasses, contact lenses, they are preferred, and provide binocular tablet games to utilize the critical period of visual development. Eye-hand brain coordination vision exercises are preferred over larger screen like 10 inches tab. Should not be at a stage, the child should not play more than 30 minutes and the illumination should not be more than 60%. But as per the severity, 2 to 4 times the games can be played. Go for Lazy Eye Master games on Android Play Store. and the child can play the games very easily. Eye, hand, brain coordinations. These are available, and if especially in case of corneal opacity, if you perform a keratoplasty after the critical period and sensitive period is over, the chances of getting the visual results are far, far better. But if you, in children or in babies, if you perform after the critical period, then the vision doesn't improve much. Then strabismus surgery should be performed as an emergency procedure, especially in one-eyed esotropias, strabismus fixus. Madam has already shown you how to see whether there is a strabismus fixus or not. Then bilateral strabismus fixus, eccentric fixation, congenital sixth nerve palsy, essential infantile esotropia. In all these cases, the purpose is also enhance the visual acuity that promotes the development of crucial visual functions and the binocular reflexes and the depth perception too. Then cyclorefract. In all these cases, when you are performing surgery in children below the age of 3 years or in babies, cyclorefraction and detailed fundus examination is very, very important. Because I have seen one case was operated for strabismus, and afterward they found that the child was having a retinoblastoma inside. So it is always to perform a refraction. That refraction will give you exact number of glasses post-operatively. That you cannot do in babies. So these two things you must perform before performing the surgery on table. Take the advantage of the anesthesia. Okay? And one more tip I would like to give you. You can use, there is a Fugo blade is available in the market now. It's a very nice Fugo blade, means it is a sort of blade where there is no bleeding or there is no inflammation of that particular muscle. This was by Dr. Fugo. And one more, this surgery which I am showing, here I am using two visco cannulas here. Can you see? Without any muscle hooks, I am using visco cannulas. This visco cannula, if you bend, you can use as a muscle dissector also, dissecting different areas of that area during muscle surgery. And a simple trick too. In this case, have you observed one important thing which I would like to show you? That in this case, I have kept the peripheral part of the muscle intact, and I excise the central part of the muscle like this. So that these two things, you will never have any problem of lost muscle, medial rectus lost muscle, or anterior chamber ischemia. This can be prevented by this. Madam has already shown you a very nice technique also, that is plication technique. But there again I feel that during plication, if you are folding the muscle, there are again chances of obstructing the blood vessels and nerves. I don't know exactly, she is the better person to tell that. And this is a simple technique. I have performed more than 1,000 surgeries like with this new technique, and I am very happy. You can try this technique while performing all 4 muscles at a time. You can perform with this simple technique. Thank you very much.
Thank you, sir. It was wonderful talk and wonderful video you showed us. The new technique we were just discussing. We were planning to start this technique, what you showed here. Yeah, we do. We can do that, sir. Should we wind up or should I?
Dr. Shreya is going to talk on ocular burns. This is the most common part in pediatric practice. and she will highlight all these different important points for that. Dr. Shreya. Try to visit her clinic in Gujarat, Dahod.
Thank you so much,
Drushti
sir.
Eye
We
Institute.
wish all to come there.
Drushti Eye Institute. बोल बोल.
I've done full screen, it's not. I'll just speak on, thanks again Dr. Deshpande sir for the nice introduction, and Dr. Rishi also. It does, the thing we must also know when we are talking about pediatric patient, how children are just getting burned by chemical, and it's most common in our area, rural area, because the father sends baby to get tuna packet from the shop, and we get lot many tuna injuries. Acid, it's okay, it doesn't work, it doesn't penetrate much. Exception is hydrofluoric acid, but alkali is a worst and curse for the children when they just get burned by alkali. So you have to take care of alkali burns specially. There are lots of classification, Huggies and Roperol classification, and nowadays newer classification which involves the conjunctival involvement also. When we are talking about the management, you have to take care of all the phases, like immediate phases, acute phase, early reparative, late reparative, and sequelae. So whenever there is a conjunctival burn, lots of inflammation and copious discharge will be there. Congestion, widespread necrosis of the cornea also can be seen. So you need to take care of this part as emergency response in an ophthalmic examination. You have to pour a lots of saline cedar eye wash, or sometimes we have to take Morgan lens to take the support to pour the material, and we can do just simple fluorescein examination and swipe up the fornix. Whatever material is there, you have to take it out and then examine for the limbal necrosis properly. So what is our immediate goal is promote the epithelial healing properly, reduce pain, decrease inflammation, and prevent bacterial infection. The management of grade 1 chemical injury usually is simple as erythromycin or bacitracin eye ointment, or sometimes we may have to support with topical steroid along with topical cycloplegic, but should be followed up on all each and other day. Whenever there is a grade 2 to 4, we can just support with topical steroid, long acting cycloplegic, sometimes scopolamine. It's very difficult to give scopolamine, so we give just simple cycloplegic. Topical broad spectrum antibiotic, oral tetracycline works very well here, and we have to take care of IOP control and high dose of vitamin C fortified in any soothing drops which works very well. So chemical patients you have to see daily you have to call, and sometimes you have to give progestational steroids such as medroxyprogesterone, and then comes the surgical management. So as this is a list of things we will give as an emergency response. Even if you give all the medication and still the inflammation persists, don't forget to look, double evert the lid, and you can see there is a lime particle lying under the superior fornix. That is the cause for inflammation. So whenever there is conjunctiva and cornea, there are the stages: acute loss of inflammation, copious discharge, as I said, early reparative can be first in 2 stages, and then later on it may come with symblepharon and chyloblepharon, obliteration of fornix or contracted fornix. So you need to take care of that. Surgery is usually debridement and surgery. Overall goals in the therapy is restore the corneal clarity, normalize the ocular surface, and prevent glaucoma and anterior staphyloma. So in this baby we performed, we removed the symblepharon what was there, and extensive removal of symblepharon, and then later on we put the amniotic membrane. Then we took limbal cell from the normal other eye. We distributed on this AMG, and that technique is called SLET technique, superior epithelial limbal transplant. So you have to cut, so you are taking support of other limbal stem cells also along with AMG, and this SLET technique works extremely well whenever there is a chemical burns. So this was the second day post-operative, and then later on you can say how with slat technique improves and then cornea gets clear, which was published in this all series of techniques published in IGO from our institute. Early repetitive phase in chemical burns of conjunctiva, again if there is a diplopia in symblepharon, simple symblepharectomy or with or without AMG and MMG works. So simple excision is seen here, and late sequelae there will be extensive symblepharon. So then again you have to put amniotic membranes, but you have to release all the scars and symblepharon with extensive dissection up to the back of the muscle. Sometime in children, if there is we put amniotic membrane and we may land them in amblyopia. So we have devised a newer technique. We just put central hole in the amniotic membrane itself. It acts as a pinhole, so there will not be a amblyopia. Leads, whenever there is a chemical burns for leads, socket, lacrimal area and orbit, lead there will be immediate full thickness lead tear can be there. We have seen lots of patients with that. And then these are the sequelae. Immediate phase of the skin care, you need to take care. You can have, sometimes you have to take support of skin specialist whenever there is thermal burn or excessive lead burning with that. And then first let the edema reduce, and then patient may come up with ptosis. Again, this ptosis can be secondary to symblepharon. So again, symblepharon release. Here we have placed mucous membrane graft after symblepharectomy. So that also works very well. So this is the post-operative after 3 months, and cornea regains the clarity back. So sometime we may come across strabismus due to burns. So because that alkali has totally penetrated the muscle, and that is adhesion in muscle. So in this patient we have just put glue, we covered it with non-absorbable material, and then the freeing of the muscle movements. But don't forget to put the fornix forming suture in this kind of patient. Later on patient may come with entropion, manage the entropion correction simply, or come with trichiasis. Then we have our own technique, which is ciliary bed transfer. We just release the whole, take out whole rows of the trichytic lead. We just pass it through the anterior of the skin, and we transfer whole bed of this laches anteriorly. So that works very well, and there will never be a recurrence of this thing. And then properly the cornea will be clear if you do this technique. So this is the same patient after 3 months, cornea got clear. Again, sometime we may have to take mucous membrane graft. So release all the trichytic lead, and then take mucous membrane from the mouth and then placed on the lead. So that also will take care of the keratinization which had happened due to burns. So in this girl there was lots of keratinization causing corneal opacity, and this is a simple mucous membrane grafting. Sometimes there is lots of entropion with sulcus deformity, lengthen the posterior lamella with canthotomy. Trichiasis with upper entropion, there will be a reason for sulcus deformity. Volume augmentation in this kind of patient works. Sometimes patient comes with enkyloblepharon, release the enkyloblepharon simply, and you will see the patient. Cicatricial ectropion, or patient comes with lag ophthalmos, you just simply can do tarsorrhaphy, or tarsorrhaphy along with the skin grafting must be done. So whenever there is entropion, just posterior lamella lengthening, ectropion, removal of cicatrix, trichiasis, ciliary bed transfer, and lead defect correct automatically. Orbit, I will not go into detail of it. There can be a shallow fornix, shelled fornix, obliterated fornix, wet contracted socket, or dry contracted socket. In all the things, the most important part you have to have with you is amniotic membrane. So when you put amniotic membrane and release the scar, that works. In this patient we had again put a mucous membrane graft, and that also worked very well, and then fitted with the prosthesis later on. So and as I said repeatedly, there should be fornix formation. You should not forget to put the fornix forming sutures. Sometime you have to do skin grafting. So this is a fornix forming suture along with the symblepharon ring will prevent the recurrence, or sometime you have to simply put conformer. This is an interesting baby which had in this baby we had done volume augmentation and fornix with amniotic membrane. So with this dermis fed graft we have put in this patient, then we did canthotomy, and this is the gratifying result we may get. But this kind of patient we have to touch sometime, and that is very, very difficult to manage. Lacrimal area I'll not cover, which is already published, so we can talk later on. Thank you so much. Thanks a lot, Deshpande sir, and we are just running short of
Yeah,
time.
Dr. Shreya, you are doing an excellent job
Thank you,
and
sir.
treating
Thank
all
you
these
so much.
very most difficult cases, very difficult cases. You have used that stem cells, limbal stem cells, amniotic membrane and everything very, very nicely. Thank you very much.
Thank you so much, sir.
We are running short of time. Actually, we got the hall a bit late, so I won't go into the details about this. I think many of you are postgraduates here. Am I right? Yeah. So can I just share one video to you, and you have to diagnose what it is. The clue was there in the previous slide, obviously. But tell me which eye is the problem eye, and what is the diagnosis? She's a 8-year-old girl. Parents complained of some abnormal movement. They were not sure what exactly it is. And when you get this kind of history, you have to think in terms of some kind of vertical strabismus. Okay. So, are ye chalu? There is a V pattern here, right? And anything here? The elevation in adduction is limited in the right eye. Okay. When you get this kind of picture, it can be either inferior oblique paresis in that eye, or more commonly it is what we call it as Brown syndrome. Brown syndrome. Brown syndrome can be unilateral or bilateral. Like in this case, it is bilateral, but 96% it can be unilateral. Usually it is common in females. Okay, but it's not that is not seen in males also. So this is Brown syndrome. Majority of these cases don't need surgery. We operate only if there is an abnormal head posture. Remember that few cases of Brown syndrome tend to improve with time, so don't immediately jump for operating these cases. Brown syndrome can be, initially it was thought to be related to superior oblique sheath, but later on it was found to involve the entire superior oblique tendon beyond the trochlea, and this was confirmed by Harold Brown. That is why it is called Brown syndrome. It can be confusing with inferior oblique paresis, which is rare, in which case we do a force reduction test. I'll just show you this video how to do a force reduction test. For obliques, you have to press the globe down into the orbit, and for recta, you have to lift it up. So when you press it down, and then you rotate, I mean you do excyclotorsion and encyclotorsion. If you get limitation on excyclotorsion, then think in terms that the superior oblique is not allowing the excyclotorsion to take place, and that can be confirmation that it is Brown syndrome. Clinically also it can be diagnosed. It can be either with esotropia as in first case, or it can be with exotropia. So horizontal strabismus can be present, but if there is no abnormal head posture, treat only the horizontal squints. Don't treat the Brown syndrome, because superior oblique can be a dicey muscle at times. I mean the results might not be very encouraging. I'll just two last slides. One is I mean the management plan. Whenever you get a patient with limitation of elevation in adduction, do a force reduction test. If it is positive, positive means it is tight, negative means it is lax. Okay, so if it is negative, think in terms of a paretic squint. If it is positive, think in terms of a restrictive squint. It can be either Brown syndrome, sometimes it can be orbital floor fracture, or a thyroid related orbitopathy. If it is Brown's, it can be either congenital, or it can be acquired, or sometimes iatrogenic. Iatrogenic means if you are doing surgery for a superior oblique palsy, what we call it as tuck or double breasting of the superior oblique, and if it is an extra tuck, then you might get acquired Brown's. Iatrogenic Browns. Acquired Browns can be traumatic, or it can be inflammatory. Traumatic can be because of some trauma, we need to explore the wound. For inflammation, or what we call it as orbital inflammation, you treat it with steroids or non-steroidal agent. Congenital, if it is congenital Brown syndrome, which is most common, see whether there are any abnormal head posture, which is usually a chin up posture. If there is no abnormal head posture, just leave it, don't try to manage it. If it is abnormal head posture, don't immediately jump to surgery, see whether it is improving with time. If it doesn't, then you opt for surgery, which is superior oblique tenectomy. I will just share you a video of superior oblique how it is done, and that will be my last slide. Okay, so yeah, I did a lateral rectus recession in her case. This is the right eye muscle. I am sitting on the head end. Go supero-temporally and go deep, I mean much into the fornix, because the muscle lies behind. Okay, then we hook the superior rectus. Remember that before doing this surgery, do a force reduction test to confirm that it is Brown syndrome, and also how much amount of restriction the superior oblique might be having. And after then you hook the superior rectus, stabilize it with a Jameson hook. The second hook was Jameson hook, and then you try to explore the superior oblique. The fibers are very much behind, so you give a radial cut in the conjunctiva to have a proper exposure. And and then you apply something like a Demars retractor or Barbie's retractor, and then you see the superior oblique fibers here, which are glistening white fibers. The difficult part is to hooking these fibers. One thing is they are posteriorly and also they are tight, but hooking is the most challenging part of superior oblique in case of a Brown syndrome. Ensure that all the muscle fibers are hooked, and unlike inferior oblique, which tends to bleed if you simply cut it, superior oblique doesn't bleed much, but still you can apply a peritomy, artery forceps, and then you cut the muscle in between. At the end of the surgery, do a force reduction test to see whether the muscle has loosened or not. Okay, so this is a silicone tendon expander. I will not share this. So take home points is Brown syndrome is an important strabismus entity. Congenital type is most common. Majority cases don't need treatment, and because few of the cases they improve with time also. Surgery is indicated only in abnormal head posture, and still the most commonly done surgery is superior oblique tenotomy. Always give a chair time to the patient, explain the realistic goals, that it is only to correct the head posture. The ocular motility will not be completely restored in any kind of restrictive strabismus. Okay, thank you.
Yeah, wonderful presentation, Dr. Mai. Your presentation was really wonderful. If you have any questions, you can ask till the next session starts. Now we are closing the Sposi session today, and you are most welcome to a All India conference at Rishikesh on 9th and 10th December. That there is a book available on myopia guidelines on the stall of entire pharmaceuticals. Okay, and you have special games for improving the contrast sensitivity and eye hand brain coordination games. They are available on Lazy Eye Master, that is a Play Store, Android Play Store. These games are available. You can try those games for your children on a tab, 10 inches tab, and try whether it improves or not. It improves the amblyopia very fast. You can go ahead with that. If you have any problem, you can .com. Thank you.